Chapter 23 is one part, and it is gynecologic emergencies. Women are uniquely designed to conceive and give birth, and due to the anatomical structures that women have, they are susceptible to some issues and emergencies that men will not have themselves. So we're going to go through a review of both the internal and external female genitalia. That starts with the vaginal opening, the labia majora and labia minora, and the clitoris. Then the perineum, which is the area of skin between the vagina and the anus. And this kind of gives you that anatomical picture of those parts of the anatomical structure. Internally, we know that the ovaries are that primary internal female reproductive organ, and there are normally two, a left and a right ovary. The fallopian tubes run from each ovary down into the uterus, and this is the tube where the egg, when it's released from the ovary, will go to either be implanted or not in the wall of the uterus. The uterus is that muscular organ where the fetus grows. As the uterus points down and reaches its narrowest part, that is called the cervix. The cervix opens up into the vagina. The vagina is the outermost cavity of the reproductive system and is considered the lower part of the birth canal. Here's a picture for you to see kind of a cross section of how everything fits within the body. You can see the right and the left ovary and the fallopian tube, and how it comes down into the uterus, how the uterus is a muscular structure down at that narrowing, and then the cervix, they're opening into the vagina. Ovulation and menstruation begin in puberty. While we are seeing that in younger ages, we normally see that start between the ages of 11 and 16. The onset of menstruation is referred to as menarche, and women will continue to ovulate and menstruate until menopause, which normally occurs around the age of 50. So from the age of 11 to 16 until the age of 50, if you have a female with abdominal pain, you need to consider that it could be as the result of gynecologic emergencies. That doesn't necessarily mean that they're sexually active, but it does mean that the female organs are what are causing their problem. Each ovary produces an egg on alternating months, and then when that occurs, that egg is released into the fallopian tubes. Ovulation occurs in the fallopian tubes, and then it travels down, and if it is an ovulated ovum, if it is a fertilized ovum, it will embed into the wall of the uterus, and this is where the continued process goes. If fertilization does not occur within 14 days of ovulation, so from the release of the egg and to the point that it travels, takes multiple days. If fertilization doesn't occur within the 14 days of that ovulation, then menstruation occurs over the period of 5 to 7 days. All of this is controlled by female hormones. So the cause of gynecologic emergencies can range from minor to significant, can be the result of sexual transmitted diseases to traumatic injury to sexual assault. So obviously there is a wide aspect to this in terms of figuring out what's going on. One of the issues that you can run across, which isn't necessarily considered an STD but can be caused by STDs, is pelvic inflammatory disease. This is an infection of the upper organs of the reproductive system, so the uterus, ovaries, and fallopian tubes. It mostly occurs in sexually active women, can result in an increased risk of ectopic pregnancy, which is when a fertilized egg embeds in the fallopian tube, or can increase the chance of sterility in the female. Most common sign and symptom of pelvic inflammatory disease is lower abdominal pain, which can also result in the patient having what we call the PID shuffle. They kind of penguin walk. They can't have that normal stride that you have without that pain. Sexually transmitted diseases can lead to PID or other issues, but having a sexually transmitted disease doesn't mean that the patient has a PID. One disease is chlamydia, also known as the clap. This is the most common sexually transmitted disease. It is caused by a bacteria and often has little to no symptoms. And this can spread to the rectum, progress to PID in women. Men and women can both have chlamydia. Another one is what's called bacterial vaginosis. This is the most common vaginal infection. And this is where you have an overgrowth of other bacteria that kind of takes over the normal bacteria that is there. Untreated, this can cause premature delivery of pregnancy, low birth weight, pelvic inflammatory disease, and obviously discomfort, pain, discharge, kind of a realm of other issues as well. And then there's also gonorrhea. This grows rapidly and grows and multiplies in warm and moist environments of the reproductive tract. So in women, this would be in the cervix, the uterus, and the fallopian tubes, and then in both in the urethra. Problem with gonorrhea is that if it is left untreated, it can enter the bloodstream and spread to other parts of the body. So, it's definitely important that if this is a risk of your patient, that you impress upon them the importance of getting seen by a doctor and appropriate treatment. Vaginal bleeding. It's easy to consider vaginal bleeding to be menstrual bleeding, but in fact, vaginal bleeding can be caused by a variety of other issues, or it could be that it is menstrual bleeding, but it's not common menstrual bleeding for your patient. Some of the other reasons that your patient may have vaginal bleeding include an abnormal menstruation. So where most women will have a menstrual cycle for 5 to 7 days, some people may experience 2 to 3 weeks worth of bleeding. Vaginal trauma, an ectopic pregnancy, spontaneous abortion or miscarriage, and then polyps or cancer in the reproductive tract can also cause vaginal bleeding. So it shouldn't be written off, but it's definitely obviously something that requires more communication with your patient to figure out what it could be. It's important to get accurate and detailed assessment. Obviously, or I unfortunately shouldn't say obviously because there have been issues, we don't do internal exams, nor do we do ultrasounds in the field that will allow us to reach a final diagnosis as to what is happening. But what we can do is use our patient assessment to get a primary impression about what's going on and what potential issues are. We can use our patient assessment to determine what treatments are necessary to ensure that our patient is comfortable and that we are doing the life-saving measures that they need. And it starts, of course, with the seeing size up. Recognize that if this comes out that has a vaginal bleed and the dispatch is for vaginal bleeding, you need to be concerned, obviously, about appropriate PPE. Gynecologic emergencies can involve a significant amount of blood. And so you want to make sure you've got gown and gloves and even eye protection if necessary. If this is a sexual assault, you definitely want to get law enforcement involved, whether you know immediately or you find out at some point in the call, in the attempt to interview your patient, it comes out. You also need to be prepared if this is a sexual assault. It's possible that They may not want a male patient or a male provider. So a female victim of sexual assault may not want a male provider to take care of them. And so you've definitely got to consider ensuring that you have a provider who can assist. Mechanism of injury should be easy to understand based on the dispatch information. But if it's not something simple like a sexual assault or a known miscarriage, it's going to take you talking to the patient and getting a good history to understand exactly what could be going on and why you're there. Immediately form a general impression. Is there a significant amount of blood loss that you need to be concerned about? Or is this someone who, when you get there, their color is really bad, but there is no external bleeding? That could be the sign that there's internal bleeding going on. What is their airway? Are they breathing? Are they breathing adequate to support life? Do they need oxygen? Are they in shock? What are you looking at in the realm of this? What's their pulse and skin color and temperature and condition? This might give you an idea of whether or not they've been fighting this issue for a while, or whether or not they're in shock. Are they in compensated shock or decompensated shock? Thankfully, most of our gynecologic emergencies are not life-threatening. However, because we might not see the bleeding, internal bleeding again may not have become external yet, you do need to be looking for signs and symptoms of shock to give you an idea that this is more significant than it originally presented as. Let's do good interview. Let's do a good questions. And it's going to seem very personal, some of the questions that you're going to ask, and it might seem very awkward. So you do need to use caution when you're interviewing your patient. You need to make sure that you're providing them any necessary privacy to ensure that you're getting the true answers from them, especially if they are a younger patient. You've got a 15, 16-year-old female and you're asking about their sexual activity. In front of their parents might not get you the best answers. So try to provide them a little privacy and ensure that they have an opportunity to give you the correct answers. And obviously no judgment in the answers that they give you. When you are looking at a patient who's complaining of abdominal pain or significant bleeding, then obviously onset, how long ago did it start? Is it consistent? Does it go away? Things make it worse or better? All of these are the questions that you want to ask. But you also want to ask about some of the other symptoms like you see on the slide here. Are they syncopal? Have they passed out or lightheaded, weak, nausea? If you've got a patient who has not, there's no vaginal bleeding, but they're feeling lightheaded and dizzy, and they've got significant abdominal pain or significant bloating, then, there's a concern there that there's something bigger going on. You just can't see it. For patients who have vaginal bleeding, again, onset and duration are big, but the other thing might be to ask, how many sanitary pads have they gone through? How frequently have they had to change the pads? These obviously, heavy bleeding, normally you look at about one pad every 4 to 6 hours, and it's not always soaked, but maybe they are now changing the pad every hour. If they've just had some type of surgery, reproductive surgery, they send them home with notes that say if they've filled the toilet bowl with blood, that's obviously a bad sign. So ask these types of questions. How much blood would they say they've lost? And again, we're asking about symptoms of syncope, lightheadedness, nausea, and vomiting as well. Get a sample history, ask about birth control or whether it's a pill or some other device like an IUD. Find out about their last menstrual period and a history of any STDs or are they sexually active. All of this is important as you start to try to figure out what's going on. In your secondary assessment, we want to look at vital signs, obviously, and you need to be looking at the abdomen. You need to expose the abdomen and look for distension and tenderness. You need to determine whether there's any visible vaginal bleeding that is occurring. Again, we're not doing an internal exam, and you need to look at their mental status. You know, is there a significant enough bleed that now they've reached the level of altered mental status? You know, so again, palpation of the abdomen, note any visible bleeding, and if there is visible bleeding, you know, provide them an appropriate trauma dressing or sanitary napkin, and then check their mental status. You know, we've got to protect the woman's privacy. We've got to be concerned this isn't, you know, this isn't a spectator sport as you're looking for any external trauma to the genitalia. You know, definitely focus on the nature of illness and their chief complaint. You know, if you don't, you know, especially with sexual assault patients, they may not want you to physically examine their genitals. And so you have to use caution. You definitely want to be careful but build their trust and give them the respect they deserve. Visualize bleeding, ask about quantity, quality, you know, is it dark in color, gushing? When they stand up, do they feel like there's more bleeding? Use external padding to control the bleed. Look for any discharge, and again, ask about the syncope, the fever, the nausea, and vomiting. These are significant issues. They don't necessarily make the patient a high priority, but this is somebody who needs to get seen and who needs to be transported with supportive care. You know, we're getting a full set of vitals, you know, and none of those are different than any other medical call, except for the orthostatic vital signs. Basically, what that means is when they're lying down, when they're sitting up, and when they're standing up, are there significant vital sign changes? You know, if they've got bleeding in their abdomen from an ectopic pregnancy or a ruptured cyst, you know, it's possible that when they stand up, that bleeding shifts. And as a result, you'll see a change in the blood pressure significantly. But, you know, we're not going to hold transport just to get vital signs in a laying down, sitting up, and standing up position. Look at pulse oximetry and monitor that blood pressure. Make sure that you are not catching the low blood pressure too late. So because abdominal and gynecological emergencies can often have internal bleeding with no signs beyond abdominal pain, your blood pressure monitoring may be the first sign you really get that this patient's in worse trouble. Our reassessment, really, because there's few interventions beyond oxygen and treating for shock, our reassessment is going to focus on the primary assessment. It's going to focus on prompt transport and on ensuring that we provide appropriate notification and communication to the receiving hospital. If this is a sexual assault, they're going to want time to get the sexual assault nurse examiner there. If this is a pregnancy, they're going to want time to make sure that the OBGYN is on call or that they have the resources that they need. You know, if this is a crime, obviously, you know, law enforcement needs to know where you're taking them. And all of this needs to be communicated as you arrive, before you get to the hospital, but as you're transporting the patient. So, after we assess, you know, we need to look at the emergency care that we can provide. If you can, have a female EMT participate in the patient's care as much as possible. Don't go examining the patient or asking them to remove their pants and underwear to look in the middle of the mall or the middle of the grocery store. Get them into the back of the ambulance where there's much better privacy. And remember that it doesn't matter whether this is a ruptured fallopian tube, whether this is just abnormal menstrual bleeding. It doesn't matter the cause of what is going on more than it matters how you treat it. Providing oxygen, treating for shock, so covering them with a blanket or putting them in Trendelenburg, and transporting are much more important than figuring out the specific cause of this emergency. Continue the use of the sanitary pads, of the pads that, use more if you need to. Remember that any trauma to the external genitalia may be significantly painful because of the high number of nerves. The nerve supply is very rich there because of the sensations. But as much as those nerves can provide pleasurable sensations, they can also provide painful stimulation as well. So ice packs and using trauma dressings or sanitary pads to assist in controlling bleeding is helpful. If you can, treat external lacerations with moist sterile compresses. So don't put an ice pack directly on the wound. Put a sterile dressing and then the pack. One of the concerns with sexual assault is, whether or not your treatment is going to impact any evidence. Obviously this is a crime, and whether the patient chooses to pursue criminal action isn't your problem, except for the fact that your treatments can compromise evidence. Keep in mind, though, that you should never withhold treatment for the sake of evidence, especially when it comes to making sure your patient survives. So, definitely minimal interventions as it relates to potentially damaging evidence, but your patient's care is first. And never pack or place dressings internal. We always only treat externally when it comes to genital trauma. Specific to pelvic inflammatory disease, as I said, it is made worse by walking, the pain. So they will likely shuffle. Don't ask this patient if they can walk to the stretcher. Bring them a stair chair or a stretcher. And really, there's not anything you can do beyond transporting them for assistance. It's a non-emergency transport. Provide them supportive care, let them be in the position of comfort, and get them to the hospital. Unfortunately, you will run sexual assaults, whether it is sexual assault of a child or of a woman, or even of a man. It is common. 1 in 5 women has reported being raped, and 1 in 4 has reported sexual molestation. There are a lot of complex issues associated with this, and so, kind of like the psychological emergencies, when you're dispatched to a sexual assault, safety is a priority, and patience with the patient is a priority as well. How you manage this can impact the patient as well as you. So the goal here is professionalism, kindness, sensitivity, be non-judgmental, regardless of what you think of the actions or the behaviors of the patient. You don't judge them or provide your input into anything. It's possible that your patient was drugged prior to the assault. So you may see a patient who is exhibiting the signs and symptoms of the effects of those drugs. So if they've been given Rohypnol or Ruthie, they may not even remember the events leading up to what happened. They may have had a period of blacking out or kind of have foggy and cloudy memories. If the drugs are still in the system, you're going to see the signs and symptoms associated with that. That could be hypotension, bradycardia. Remember, these drugs are designed to depress the central nervous system. So if the wrong amount of the drug was given or they took too much, you could see seizures and coma in these patients as well. As long as it was dispatched as such, you will likely see police. As I've said, though, if you are in the middle of an interview of a patient who police aren't on scene and it comes up that this was a sexual assault, get law enforcement involved as soon as possible. But don't let law enforcement necessarily get in the way of you being able to treat your patient. Again, your priority is the patient, not getting the perpetrator, not catching the bad guy. Your goal is to give the patient the care that they need. We try to make sure that the crews are mixed so that there is one female and one male on these crews, so that the patient can have the option of which gender EMT they want. I've seen sexual assault patients who wanted the female EMT because, they had been assaulted by a man and they didn't want a man assessing them. But I've also seen sexual assault patients who were assaulted by a man, but they didn't feel safe. They felt a male EMT could provide them more protection in case the criminal came back to re-assault them. Our focus is the patient. Our focus is providing medical care. Our focus is providing psychological treatment. So, giving them the ability to talk while you listen, preserving evidence as much as possible. Again, not if it hinders patient care, and getting them to additional assistance. When we're treating our sexual assault patients, remember that the likelihood is that this is something that could end up in court. So make sure your documentation is appropriate. It is thorough. You document what you found and what the patient said, that you record the facts, that you conduct your interviews objectively. Discourage your patient from bathing, vomiting, using the restroom, or drinking or eating anything, because that can actually get rid of evidence or compromise evidence. And again, transport to a hospital where they have a sexual assault nurse examiner or a SANE nurse. And because they are able to more appropriately fully examine the patient in a way that provides the most evidence should this assault go to court. But again, our goal and our primary focus is to treat the patient and the injuries that exist as a result.